Hi folks, welcome to my YouTube channel. So in this video and in our upcoming videos, we will discuss about the interstitial lung diseases, especially those who are related with the cigarette smoking. So in this video, we will discuss about the respiratory bronchiolitis and the respiratory bronchiolitis interstitial lung disease with the fibrosis. So before we discuss about the RBILD, so here is the histological algorithm how to approach these chronic interstitial pneumonias or the interstitial lung diseases. So first of all, these type of lesions are not like a one discipline type of a diagnosis. It's a multidisciplinary diagnosis. We need information from the radiology, we need information from the clinical team, and then finally it comes to the pathology interpretation. So there are multiple interstitial lung diseases, but here in this video we will focus only on the RBILD and how we can approach RBILD with the help of this algorithm. And when we will discuss about the other lesions, then we will continue revisiting this algorithm. So the first of all, when we have a either wedge resection or either we have a biopsy, then on the low power, first we have to make a determination whether the lesion is diffuse versus the patchy. Means the lesion is present throughout or lesion is present the lesion is present in one side and the other side we have a normal appearing parenchyma and the alveolar septas. So once the lesion is patchy, then we have a three differential: usual interstitial pneumonia, cryptogenic organizing pneumonia, and the respiratory bronchiolitis interstitial lung diseases. And then the second approach is that whether the lesion is homogeneous or whether the lesion is heterogeneous. Homogeneous means the lesion is present all in the same stages, while the heterogeneous indicates that the lesion is present in the different stages of the progression. And if the lesion is homogeneous, then we have a two further differentials, which is the COP versus the RBILD. And if we have a heterogeneous, then we have a one differential, which is UIP, which carries a much more poor prognosis. And then if the lesion is homogeneous, then we have to look for the centrolobular macrophages. And if they are abundant in amount, then we have a diagnosis of the RBILD. So before we discuss about the definition, so the term respiratory bronchiolitis is a confusing term itself. It implies that there is an inflammation of the respiratory bronchioles. So here the ITIS mainly refers to the presence of the macrophages, and the macrophages are not only confined to the respiratory bronchioles only. They goes further down. They can involve the alveolar ducts and they can involve the alveoli as well. So by definition, it is an accumulation of the pigmented laden macrophages, which they are also called as the smoker macrophages within the lumen of respiratory bronchioles. Alveolar ducts are in the alveoli, and it has been proven by some higher technologies that the pigment which is present in these smoker macrophages is the same type of a pigment which is present into the cigarettes. That's why these macrophages are also known as the smokers macrophages. And the presence of the respiratory bronchiolitis indicates that the patient is either a currently smoker or the patient is an former smoker. So discussing about the epidemiology, like 98% cases of the RB are related to the smoking history, and sometimes in the rare cases the environmental exposure such as dust, fumes are also involved, and it equally involves the males and the females. While the clinical presentation, majority of the cases of the respiratory bronchiolitis are totally asymptomatic, and if in case they are present, the patient commonly present with the dyspnea followed by the cough. While the pulmonary function test can be totally non-specific in these type of the lesions, it can lead to the obstructive or restrictive pattern, because smoking is not only causing the respiratory bronchiolitis into the lung, it can lead to the emphysema, which can give rise to the obstructive type of a pattern. It can lead to the advanced fibrosis, which can causes the restrictive type of the diseases. So the pulmonary function test in these type of lesions can be normal, either can give rise to the mixed pattern, or either obstructive or restrictive, depends on which factor or pattern is predominant. While discussing about the radiology, so mainly in these type of lesions, the respiratory abnormalities are hardly detectable. But if in case they are present, they will give rise to the centrilobular nodules or multifocal ground glass opacities, and mainly they are pronounced on the upper lung fields. So here is the one of the CAT scan of the ground glass appearance on the upper lobes, which is mainly one of the sign of the respiratory bronchiolitis. But these nodules are either the ground glass opacities can give rise to the clues towards the respiratory bronchiolitis. They are not mainly specific for these type of the conditions. So discussing about the microscopy, as we discuss in our histological algorithm, that first on low power we have to look whether the lesion is diffuse or whether the lesion is patchy. So on this low power we can see that the lesion is present here, while the adjacent alveoli are little bit expanded, but there is nothing into the lumini. So the first thing is that the lesion is patchy. Then we have to look whether, if it is a patchy, then whether it gives rise to the homogeneous or the heterogeneous. So if we look carefully, that it has a homogeneous type of appearance, because if the fibrosis is present, then the fibrosis all looks same into the color. And the second thing is that it mainly, according to the definition, that it is the accumulation of these pigmented macrophages into the respiratory bronchioles or into the alveoli. So whenever we have these pigmented type of the macrophages, we have to keep one another differential in our mind, which is the pulmonary hemosiderosis. So how we can differentiate the hemosiderosis macrophages versus the smokers macrophages in the RB? The first thing is that the pigment into the RB is light brown. It is little bit granular and fine in texture, while the pigment which is present into this pulmonary hemosiderosis, because of the iron, it is much more coarse and much more darker in color. So when we do the iron stain on those, it will be helpful as well, because in the hemosiderosis it will be much more dark blue, much more coarse, while while in the RB it will be light blue and much more fine. So this is the two three features how we can differentiate the pigment present into the smoker macrophages versus the hemosiderosis. So discussing about the RBILD with the fibrosis. So as we discussed, the respiratory bronchiolitis is the presence of smokers macrophages or the pigmented macrophages into the alveoli, alveolar ducts, or into the respiratory bronchioles, while the interstitial lung disease here indicates when there is a chronic inflammation present into the interstitium of the lung parenchyma, while when there is a fibrosis, we will term as a with fibrosis. So as the name implies, when there is a prominent collagenous fibrosis, which commonly extend well beyond the bronchioles. And if we go on the high power of this lesion, here we can see that there is like eosinophilic pinkish type of a collagen is present into these alveolar septas. And in the pulmonary pathology, the Mowat stain we commonly use, it is a pentachrome stain, which is it stain of 5 different colors. But in the pulmonary pathology, we mainly focus on the 3 colors. And the first color is the yellow, which commonly highlights the advanced type of a fibrosis. Then is a greenish, which stains the mucin and can highlights the early collagen led, when the collagen is in its early stages. And then is the black color, which commonly stain on the elastin, whether it's present in the pulmonary arteries, bronchial arteries, or even into the pleura. We will discuss about the Movastatin in our upcoming videos as well. So discussing about the treatment and the prognosis about the RV is quite excellent, and the treatment mainly is the cessation of a smoking. But once the person stop or quit the smoke, the pigmented macrophages takes at least minimum of 9 years and maximum of up to 32 years to completely clean these respiratory bronchioles or to the alveoli. That's why these presence of these macrophages can indicate that the patient was a former smoker. And if in case the fibrosis is quite advanced, then the glucocorticosteroids or the immunosuppressive agents are also used along with the smoking cessation. And as we said, the prognosis is quite excellent, especially if we compare with the usual interstitial pneumonia. So this is the end of my video.